Hello, everyone. Today's session focuses on a critically important theme in reproductive, maternal, and child health: harmful traditional practices affecting the health of women and children. We'll explore these practices from a midwifery and public health perspective, examining not only what they are, but why they persist and how we, as future practitioners, advocate for change. By the end of this lecture, you should be able to 1. Define harmful traditional practices, HTPs. 2. Identify major forms of HTPs. 3. Discuss health consequences affecting women and children. 4. Explain factors that sustain these practices. 5. Recognize the role of midwives and communities in prevention and advocacy. Keep these objectives in mind as we move through the material. They will guide your focus. Harmful traditional practices are not merely cultural habits, they are violations of fundamental human rights. CEDAW, the Convention on the Elimination of All Forms of Discrimination Against Women, emphasizes eliminating discriminatory practices affecting women. CRC, the Convention on the Rights of the Child, stresses the protection of children from all forms of physical or mental harm. UDHR, the Universal Declaration of Human Rights, reinforces bodily integrity and dignity. So, we approach HTPs not only as health risks, but also as ethical and legal concerns. Despite harm, many communities continue these practices because they serve a social function or are seen as normal. Key drivers include cultural identity, male benefits, patriarchal values sustain control, inheritance systems and marriage arrangements, illness prevention. Some practices are mistakenly believed to protect health or fertility. And tradition. The phrase, "this is how we've always done it," is powerful and emotionally binding. FGM is one of the most worldwide recognized forms of HTP. Definition: removing, altering, or injuring external female genitalia for non-medical reasons. Prevalence: practiced across parts of Africa, the Middle East, and Southeast Asia. Purpose: often believed to ensure purity, marriageability, and obedience. As a reminder, FGM has no health benefits. It only creates harm. FGM is categorized into 4 primary types. Type 1, clitoridectomy, or removal of the clitoral glands and prepuce. Type 2, excision, removal of clitoral glands and labia minora, sometimes labia majora. Type 3, infibulation, narrowing the vaginal opening by creating a seal through cutting and repositioning tissue. Type 4, other harmful procedures such as piercing, scraping, or burning. Understanding classification matters for clinical assessment and counseling. FGM is often performed by traditional practitioners, often older women considered custodians of tradition, midwives or TBAs who may be pressured to continue cultural norms. It typically occurs in homes, special gathering venues, and occasionally in health facilities, especially where medicalization is increasing. Communities rationalize FGM using a set of recurring arguments: cultural, beliefs about identity and womanhood; religious, misinterpretations of religious teachings; societal, pressure to conform for marriageability and status; misconceptions, false beliefs that the procedure promotes cleanliness, fertility, or morality. These beliefs must be challenged respectfully and evidence-based. FGM can trigger severe short-term complications: hemorrhage, sometimes life-threatening; shock; infection or sepsis; urinary retention and pain; suture problems, especially with infibulation; severe trauma or psychological shock. Many girls suffer silently. Some do not survive. Chronic consequences include gynecological, chronic pain, infection, abnormal bleeding, obstetrics, obstructed labor, perineal tears, need for episiotomy, fistula formation, cesarean delivery, sexual, dyspareunia, and reduced or absent sexual pleasure, psychological, depression, trauma, anxiety, and PTSD. Another form of harmful gendered practice relates to son preference, where male children are valued more highly than females. It is driven by economic factors, cultural expectations, and inheritance systems. Resulting consequences include neglect of girl children, reduced access to nutrition, healthcare, and education. Son preference affects girls across multiple domains: health, malnutrition, and delayed health care; education, lower enrollment and higher dropout rates; social status, reduced autonomy and self-worth. These impacts extend throughout adulthood. In extreme cases, son preference results in infanticide or foeticide, sex-selective abortion facilitated by technology. Consequences are demographic, distorted sex ratios, and long-term social imbalance. Early marriage involves girls under 18, pressure from family or community, exploitation through marriage and bride price. Early marriage increases vulnerability to violence, dependence, and reproductive harm. Girls become pregnant before the body is physically prepared. Health consequences include low birth weight and neonatal morbidity, cephalopelvic disproportion, causing obstructed labor, and higher maternal mortality. Certain foods are restricted during pregnancy or lactation. Common examples include eggs, fish, meat, bananas, depending on region. Consequences include micronutrient deficiencies, anemia, poor fetal growth, and breast milk insufficiency. Some delivery traditions pose harm, such as herbal or toxic preparations, forced fundal pressure, rigid birthing positions, and traditional cord cutting with unsafe tools. Each introduces avoidable risk. Gishiri cut refers to cutting the vaginal wall to treat obstructed labor, infertility, or sexual dissatisfaction. It is medically unnecessary and causes severe bleeding, infection, long-term reproductive damage, and emotional trauma. VVF is often a consequence of obstructed labor or unsafe childbirth practices. Complications include incontinence, infection, social rejection, and stigma. Many affected women experience isolation and profound psychological distress. This involves widening or cutting the vaginal introitus. Possible complications include infection, bleeding, scarring, and chronic pain. Violence includes physical, emotional, and sexual harm, often tied to gender norms, control, or punishment. Survivors may require long-term medical and psychological support. Global efforts include United Nations resolutions, human rights bodies, and policies addressing gender inequality and cultural violence. NGOs contribute through education, awareness, and advocacy, support programs, and community partnerships. Many countries now have laws banning practices such as FGM. Examples include prohibition of FGM acts, anti-child marriage laws, domestic violence acts, and sexual offenses acts. However, enforcement varies widely. Education strengthens empowerment, critical thinking, and resistance against harmful norms. Schools, health systems, and media all contribute to change. Men must be included in advocacy because they often influence decisions about traditions. Gender equality requires shared responsibility. Midwives must provide evidence-based counseling, advocate against harmful practices, respect cultural contexts while prioritizing safety. Our role extends beyond clinical care. mobilizing communities, challenging harmful beliefs, supporting survivors, and partnering with policymakers and NGOs. Effective practice requires respect, empathy, non-judgmental communication, and shared decision-making. This builds trust and opens pathways for change. To conclude, tradition is not static. Cultures change. By empowering women, supporting families, and advocating for safe and respectful care, harmful practices can be challenged and ended.